Hello, good day to everyone. I'm Peng Seng from Hospital Pulau Pinang. This is our research title. We can focus on the highlighted keywords, which are low dose oral alfacalcidol, dialysis patients, and secondary hyperparathyroidism. All dialysis patients would have reduced renal function. As a result, phosphate retention will occur. At the same time, there's reduced activation of vitamin D by the kidney. This then leads to lower calcium absorption and lower serum calcium level. All these three factors stimulate the parathyroid gland to produce more parathyroid hormone. In the long run, hyperparathyroidism will occur and contributes to bone fracture and vascular calcification. In turn, this increases the patient's risk of cardiovascular disease and mortality. We can treat hyperparathyroidism by using phosphate binder to reduce the phosphate level and vitamin D receptor agonists to suppress the parathyroid hormone. This is our first Malaysian guideline published in 2018 specifically for the treatment of CKD mineral bone disorder and parathyroidectomy. Alfacalcidol and calcitriol are the only VDRA available in our Ministry of Health formulary. Both are non-selective, meaning that they can bind to the vitamin D receptor at the parathyroid gland and the gut equally. For dialysis patients, the intact parathyroid hormone level should only be monitored every 6 months if following the Malaysia CKD mineral bone disorder guideline. In May 2019, all prescriptions from HPP's nephrology unit with calcitriol were converted to alfacalcidol with equal dose. For your information, calcitriol is the activated form of VDRA while alfacalcidol needs liver activation. So, all the factors mentioned just now actually prompted us to do this research in order to determine the treatment outcome of low-dose oral alfacalcidol in dialysis patients with secondary hyperparathyroidism. Specifically, we wanted to determine the effectiveness of low-dose oral alfacalcidol in suppressing parathyroid hormone within 52 weeks. We also wanted to identify the side effect profiles in terms of high calcium, high phosphate, and low parathyroid hormones that may be caused by low-dose alfacalcidol. We wanted to evaluate the achievement of target lab results set by the Malaysian guideline. We also tried to calculate the total cost of alfacalcidol capsule prescribed over 52 weeks. This is an observational prospective cohort study. The subject's VDRA and calcium carbonate dose, serum intact parathyroid hormone, corrected serum calcium, phosphate, and alkaline phosphatase level were collected from the medical record into data collection sheets. Their baseline data in May 2019 were collected retrospectively, and data at week 52 were collected prospectively. There was no washout period when switching from calcitriol to alfacalcidol. Therefore, the baseline data reflected the patient's condition while they were still on calcitriol. The prescribers were unaware of this study and they can adjust the alfacalcidol dosage during the study period based on the patient's clinical condition. We recruited all in-house dialysis patients who were 18 years or older. Their oral alfacalcidol dose should be lesser than 3 micrograms per week. Their baseline serum intact parathyroid hormone should be at least 150 picogram per ml. We excluded patients who were taking calcium mimetics such as Calcet, or had history of parathyroidectomy, or had concomitant chronic or malignant liver disease or gastrointestinal disease. Using data from previous study for sample size calculation, it shows we need 35 subjects in order to reject the null hypothesis with power of 0.8 and type 1 error of 0.05. Eventually, we managed to include 76 subjects in our study. The data was analyzed using SPSS version 16. Continuous values were expressed as the mean with standard deviation, and categorical variables were presented as numbers with percentage. The pair t-test was used to compare changes of VDRA and calcium dosage, serum IPTH, corrected calcium, phosphate, and alkaline phosphatase level between baseline and at week 52. The results were significant if p-value was lesser than 0.05. Half of the 76 patients were Malay, followed by 38% Chinese and 12% Indian. Majority of them were taking calcium-based phosphate binder. Their mean age was 25.5 years old, with the majority of them being in the 60 to 79 years old group. Most of them were peritoneal dialysis patients. Their mean dialysis duration was around 4 years. Their mean calcium dose at baseline and 52 weeks was 2.37 gram and 2.4 gram respectively, and this difference was statistically significant. This equals to around 5 tablets a day. Almost all alfacalcidol were given as intermittent therapy, which means 3 times a week rather than daily dose. Nearly 2/3 of the subjects received same dose throughout 52 weeks, while 15% of them had reduced dose and 20% of them had increased dose. The mean calcitriol dose at baseline was 1.21 microgram per week. This did not differ significantly with the mean alfacalcidol dose at 52 weeks, which was 1.28 microgram per week. This translates to a dose of lesser than 0.5 microgram 3 times a week. In terms of cost, for 76 subjects over 52 weeks, while still using calcitriol, it cost nearly 5,000 ringgit or 65 ringgit per patient per year. There was a cost reduction of 24% after switching to alfacalcidol, which cost 3,780 ringgit or 49 ringgit per patient per year. Alright, now let us look at the lab result. The mean serum IPTH did show a slight increment of 6.8% from 348 to 371 picogram per ml. However, this increment was not statistically significant. The mean corrected serum calcium level remained about the same over 52 weeks. We can say the same for the change in mean serum phosphate level over 52 weeks. They did not differ significantly. There was a slight increment of the mean serum ALP level over 52 weeks. However, this increment was not statistically significant as well. Next, we look at the proportion of subjects who were able to meet guideline targets at week 52. Only 6 out of 76 subjects able to meet all the guideline targets. 9 subjects had IPTH of lesser than 150 picogram per ml at the end of the study. 6 out of these 9 subjects, or 2/3 of them, had IPTH within target range at baseline already, but they were still prescribed alfacalcidol. I'll show you this table again at the discussion part. Over the period of 52 weeks, the hypercalcemia event shows slight increment and the hyperphosphatemia rate shows slight reduction. Moving on to discussion. Alfacalcidol in itself has no doubt been very effective in suppressing parathyroid hormone. This has been shown in many other studies. However, this effect was not seen in our study, possible due to a much lower dose of alfacalcidol used. Another possible explanation might be that alfacalcidol may need 1.5 to 2 times higher dose compared to calcitriol in order to demonstrate IPTH lowering effect. However, when switching calcitriol to alfacalcidol in our hospital, it was done with equal dose. Another study showed 88% rise in serum IPTH after switching treatment from calcitriol to alfacalcidol, further supports this explanation. Our study period of 52 weeks was considerably longer than other studies, with mostly 24 weeks. Despite this, most subjects still did not achieve all target ranges set by guideline. This might be contributed by the high usage of calcium-based phosphate binder. On average, our patient took 5 calcium tablets a day. This might limit the dosage adjustment of alfacalcidol when the calcium level of the patient is high. 75% of the subjects achieved ALP level of lesser than 150 units per liter. The ALP is a biomarker to monitor bone health. ALP in target range may be associated with reduced fracture risk and lower mortality, and this is a good observation in our subjects. This is the table that I promised to show you again just now with the addition of national data from the Malaysian Dialysis and Transplant Registry 2016 as comparison. I include data back in 2016 because that is the only latest one I can find online. We have higher proportion of subjects who are able to meet the target range of IPTH set by the guideline compared to the nationwide data. It is worthwhile to note that back in 2016, most of the patients nationwide were treated by calcitriol actually. For other lab parameters such as the corrected calcium level and serum phosphate level, the proportion of subjects who are able to meet target range remain comparable. However, the point to take note here is that there are still large proportion of subjects who are unable to meet target range set by the guideline based on our current treatment strategies. There was a relatively low rate of hypercalcemia events in our study, mostly actually existed before shifted to alfacalcidol. There was a study comparing alfacalcidol with a selective vitamin D receptor agonist such as paricalcidol, which theoretically should cause lesser hypercalcemia and hyperphosphatemia, so they actually have similar events. There are many factors which can affect the phosphate level in the body, such as diet, timing of blood sample measurement, or adequacy of dialysis, so hyperphosphatemia not necessarily arise from drug treatment. As much as we want to suppress the parathyroid hormone, we also want to avoid hypoparathyroidism at all costs because it will increase risk of a dynamic bone disease and mortality. Our studies show high risk to develop hypoparathyroidism if alfacalcidol is continued after the patient has achieved target range of IPTH. There are several limitations in this study, such as relatively small sample size, no appropriate tool to measure subjects' adherence to medication. This was because at that time, Moisky scale was not allowed to be used and my mark was not available yet. There was also no control over subjects' diet, and this may affect the patient's serum calcium and phosphate level. In conclusion, low-dose oral alfacalcidol was unable to suppress serum IPTH but can slow down progression of secondary hyperparathyroidism. It is also difficult to meet all the lab parameters set by the guideline with low-dose oral alfacalcidol. However, this treatment regime does have advantages of lower cost, not increased hypercalcemia and hyperphosphatemia events drastically. What can be done next would be a complete multi-center study with a statistically acceptable sample size, which can reflect the Malaysian dialysis patients populations with secondary hyperparathyroidism. With that, thank you very much for your attention.